80%. That is how many requests for long-term hospital care one of the three largest Medicare Advantage insurers in the country denied in 2026, according to a federal investigation into exactly the kind of coverage millions of retirees are paying for right now. If you are enrolled in Medicare Advantage, or you are about to sign up for it during open enrollment, this video is going to show you which types of plans carry the highest risk of leaving you without coverage exactly when you need it, and which ones actually hold up when it counts. No scare tactics, just the numbers insurers are now legally required to publish, and what almost nobody reads before they sign. Let's start with the part that gets buried the deepest. Prior authorization. It sounds like paperwork. In practice, it is the single biggest reason people get denied care they thought they already paid for. Here is how it works. Before, your Medicare Advantage plan will pay for certain treatments, hospital stays, or rehab. Your doctor has to ask the insurance company for permission first. Original Medicare almost never does this. Medicare Advantage plans do it constantly. In 2024 alone, insurers made nearly 53 million of these permission decisions for Medicare Advantage enrollees. That is not a typo. 53 million requests just to get treatment approved. And the denial rates behind those numbers vary more than most people would ever guess. According to a 2026 federal report from the Department of Health and Human Services, the three largest Medicare Advantage insurers in the country denied long-term acute care requests at wildly different rates. One denied 80% of requests, another denied 72%, a third denied 71%. Read that again. Nearly 3 out of every 4 requests for serious, extended hospital care got turned down on the first try. Now here is the detail that should stop you in your tracks. When people appealed those denials, more than a third of them got overturned. For skilled nursing facility stays specifically, insurers overturned 95% of their own denials once someone pushed back. One major insurer overturned 99.7% of its own appeals. Think about what that means. The plan said no. The patient or their family appealed, and the plan admitted almost every single time that the answer should have been yes. Why does this happen? Prior authorization decisions are increasingly run through automated review systems that process requests in seconds, often without a human actually reading the clinical file. It is faster and cheaper for the insurer to deny first and let people fight for it later, because most people never fight at all. Across the industry, only about 6% of denials ever get appealed. The other 94% of people, many of them in their 70s and 80s, dealing with a health crisis, simply accept the denial and either pay out of pocket or go without. Picture what that actually looks like for a real family. A 78-year-old has a stroke. She is stabilized in the hospital, and her doctors recommend a stay at an inpatient rehabilitation facility, the kind of intensive therapy that determines whether she walks again on her own or needs permanent full-time care. Her Medicare Advantage plan requires prior authorization for that transfer. The request gets denied. Her family does not know that denial rates for exactly this kind of care run as high as 80% at some of the largest insurers, and they do not know that appeals succeed more than a third of the time. They are exhausted, scared, and focused on their mother, not on insurance paperwork. So instead of appealing, they accept a lower level of care, or they pay out of pocket for the difference, at a moment when they have the least capacity in the world to fight a corporate review process. That is not a hypothetical. According to post-acute care researchers, the average initial denial in this category delays treatment by 5 to 6 days. Time that matters enormously in stroke and injury recovery. Multiply that single story by the tens of millions of prior authorization decisions made every year, and you start to see why this single line item, buried in the plan's coverage documents, deserves more attention than the premium on the front page. Not every Medicare Advantage plan behaves the same way, and this is where it actually matters which plan you pick. When insurers were required to start publicly disclosing their prior authorization numbers, the spread turned out to be enormous. One major insurer denies just 2.3% of standard requests. Another denies 32.7%. That is a 14 times difference between the best and worst options sitting on the same Medicare Advantage marketplace. The program-wide average sits around 9%, so the plan you choose is not a minor detail. It can be the difference between routine approval and a fight you did not sign up for. This is also regional. Comparing average denial rates by state, Delaware, Arkansas, and Kentucky post some of the highest numbers in the country, all above 13%. North Dakota, California, and Hawaii post some of the lowest, under 6%. State rules and local plan competition shape a lot of this, which means the exact same insurance brand can behave differently depending on where you live. And it means a plan that a friend or relative in another state swears by is not automatically the right benchmark for your own decision. This matters even more if you are one of the millions of people weighing a retirement move to a new state. Since your plan choice and your denial risk effectively reset the moment you relocate. And 2026 has made that reset unusually common. Roughly 2.9 million Medicare Advantage enrollees were forced into a new plan this year alone, after their previous insurer withdrew from their county or scaled back its service area entirely. That is not a slow trickle. That is millions of people who did nothing wrong and changed nothing about their own health, and still woke up one enrollment season to find their old plan simply no longer exists where they live. If you are relocating for retirement, or if your current plan has recently changed its coverage area, this is exactly the moment to run through every number in this video again from scratch, rather than assuming a new plan in a new state will behave the way your old one did. Denials are only the first trap. The second one is the network you are actually allowed to use. Original Medicare gives you access to almost any doctor or hospital in the country that accepts Medicare, full stop. Medicare Advantage plans do not work that way. You are handed a specific list of doctors, specialists, and hospitals. And stepping outside that list can mean paying the full cost yourself. With an HMO-style Medicare Advantage plan, some insurers do not cover non-emergency, out-of-network care at all. Not a higher copay, zero coverage. With a PPO-style plan, out-of-network care is usually covered, just at a steeper cost-sharing rate, on top of needing prior authorization anyway. Here is the scenario that trips up more people than any other, and it has nothing to do with dishonesty on your part. You pick a plan. Your current doctor is in the network. A year later, your doctor leaves that network or retires, or the insurer restructures its provider list for the new plan year. That change can happen mid-year, and it does not automatically give you the right to switch plans early. You can be informed in March that your cardiologist is gone and told you are locked into your current plan until the next open enrollment window opens in the fall. For snowbirds and retirees who split time between two states, this risk multiplies, because a narrow, single-region network was never built with two addresses in mind. There is also a cost ceiling worth knowing exactly. For 2026, Medicare Advantage plans cap your yearly out-of-pocket spending at $9,250 for in-network care, or $13,900 if you count combined in- and out-of-network spending. That sounds reassuring, and it genuinely is a real protection. Original Medicare does not offer on its own. But that cap does not include everything. Prescription drug costs and true out-of-network spending on an HMO plan can sit outside that number entirely, which means the real ceiling on what you could pay in a bad year is often higher than the number printed on the brochure. There is a second layer to the network problem that rarely gets mentioned, and it applies even when you are careful. Even when your hospital of choice is confirmed in-network for a planned procedure, some of the specialists working inside that same building, anesthesiologists, radiologists, pathologists, are sometimes contracted separately and can be out-of-network themselves. You did everything right. You checked the hospital. You still get a surprise bill because nobody mentioned that the building being in-network does not guarantee everyone working inside. It is. Medicare does recognize one real safety valve here. If your plan makes what is officially classified as a significant change to its provider network, that can open what is called a special enrollment period, letting you switch plans or return to original Medicare outside the normal windows. The catch is that the plan decides what counts as significant, and a single specialist leaving mid-year often does not qualify, even if that specialist happens to be the one managing your most serious condition. Now for the trap that almost nobody explains before you sign, and it is the one that can cost you the most money over the longest period of time. Switching back. When you first become eligible for Medicare at 65 and choose a Medicare Advantage plan, federal law gives you a 12-month trial right. During that window, if the plan is not working out, you can switch back to original Medicare and buy a Medigap supplement policy without an insurer being allowed to deny you or charge you more for your health history. That protection expires after 12 months, and it does not reset later in life. Here is what that means in practice. Say you pick a $0 premium Medicare Advantage plan at 65 because the math looks obvious. No monthly premium, dental and vision included, maybe even a gym membership. 5 years later, you are diagnosed with a heart condition or cancer, and your Medicare Advantage plan's network suddenly feels too narrow for the specialists you now need. You try to switch back to original Medicare and buy a Medigap policy to cover the gaps. In most states, the insurer can now medically underwrite you. That means they are legally allowed to charge you significantly more or deny you coverage outright because of the exact health condition that made you want to switch in the first place. A policy that might have cost you around $350 to $500 a month with guaranteed acceptance at 65 can become unaffordable or simply unavailable once you actually need it most. So who is actually recommending these plans to you and why? This is the part almost nobody in an insurance office volunteers. The Centers for Medicare and Medicaid Services caps the standard commission an agent can earn for enrolling someone in a Medicare Advantage plan at $611 per person. But a 2024 Senate Finance Committee investigation found that many brokers are collecting far more than that. Sometimes over $1,300 per enrollee, through extra payments labeled as marketing dollars or administrative fees that sit legally outside the official commission cap. Total spending on agent and broker fees across the industry rose from $2.4 billion in 2018 to $6.9 billion in 2023, according to that same Senate investigation. Compare that to what an agent earns for helping someone choose original Medicare with a standalone Part D drug plan instead. By multiple industry surveys, agents report being paid up to 3 times more to enroll someone in Medicare Advantage than to help them into traditional Medicare. That does not automatically mean the advice you are getting is bad. But it does mean the person across the desk from you has a real financial incentive to steer you toward the option that pays them more. And federal investigators have documented cases of agents telling seniors their current doctor was in-network when it was not, simply to close the enrollment. A 2023 Senate investigation into this exact pattern documented something worth repeating in plain terms. Large national plans were found aggressively pulling members away from smaller, community-based Medicare Advantage plans through marketing spending. Those smaller plans simply could not match, regardless of which plan actually served the member better. One regional insurer in New York reported that 35% of the members it lost to a national competitor left specifically because of misleading marketing. Not because the other plan was genuinely a better fit for their health needs. That is more than a third of the people who switched, moved by advertising rather than by any real improvement in their coverage. None of this requires you to distrust every agent you talk to. Many are genuinely trying to help. But it does mean the burden of verification sits with you, not with the enthusiasm of the presentation. A good agent will hand you the plan's published denial rate and star rating without being asked twice. One who changes the subject when you ask about commission structure is telling you something, even without saying a word. There is one more piece of this puzzle, and it is the one that connects everything you just heard to the long-term health of Medicare itself. Every year, the Medicare Payment Advisory Commission, an independent agency that reports directly to Congress, calculates how much more the government pays Medicare Advantage insurers compared to what the same beneficiaries would have cost under original Medicare. For 2026, that number is $76 billion in overpayments. Not spending. Overpayment above and beyond what the actual care delivered would have cost. A large piece of that comes from a practice regulators call upcoding. Medicare Advantage plans are paid more for enrollees who look sicker on paper because the payment formula is designed to compensate insurers fairly for covering people with real, expensive health conditions. But some insurers have been found adding extra diagnoses to a patient's chart that were never actually treated, sometimes generated from a single in-home health assessment, rather than an ongoing course of care, specifically to push that patient's file into a higher-paying risk category. One nonprofit insurer, affiliated with a major health system, agreed to a $556 million settlement with the Department of Justice in early 2026 over exactly this kind of upcoding. A separate Senate investigation concluded that one of the largest Medicare Advantage insurers in the country was, in the investigator's own words, aggressively gaming the payment system. Why should this matter to you personally, beyond the general unfairness of it? Because Medicare Advantage payments are drawn from the same Medicare Hospital Insurance Trust Fund that eventually pays for your hospital coverage, no matter which type of Medicare you are on. Budget analysts estimate that if this pattern continues at its current pace, it could add up to roughly $1.2 trillion in overpayments over the next decade. That is not an abstract Washington number. It is a direct pressure point on how long the fund supporting your own future hospital coverage stays solvent. The plan quietly padding its numbers to boost its own payment is not just taking money from taxpayers in the abstract. It is drawing down the same well every Medicare enrollee, including you, is eventually counting on. None of this means Medicare Advantage is a scam, and it would be dishonest to tell you that. Millions of people use it well, and for someone who is healthy, does not travel much, and is comfortable with a defined network. The extra benefits and the spending cap can be a genuinely good deal. The plans worth avoiding are the ones with 3 specific traits stacked together. A denial rate well above the 9% program average. A narrow HMO network with 0 out-of-network coverage in the area where you actually live and travel. And an agent who cannot clearly explain, in plain language, why this specific plan fits your specific health situation. rather than simply telling you it is the best one available. The plans worth a real look are the opposite. And there is a second public number that lines up with everything you have just heard. Every October, CMS publishes star ratings for every Medicare Advantage contract in the country, scoring each one from 1 to 5 stars across 40 separate quality measures covering outcomes, member experience, and access to care. For the 2026 ratings, the national average landed at 3.65 stars, and just over 40% of contracts reach the 4-star threshold that unlocks a federal quality bonus. Only 18 contracts nationwide, about 3.5% of all of them, hit the full 5 stars. These numbers are not cosmetic. Plans below that threshold face more oversight, and, if the pattern continues long enough, potential contract cancellation by CMS. Here is what makes this genuinely useful, instead of just another statistic. The same insurer with the lowest prior authorization denial rate in the country, at 2.3%, also runs 100% of its contracts at 4 stars or higher, with 2 of them hitting the full 5 stars. That is not a coincidence you have to take on faith. Low denial rates and high star ratings tend to travel together because both numbers are ultimately measuring the same underlying thing, whether a plan is actually built around delivering care or around minimizing what it pays out. Compare that to insurers sitting at only 20% of their members in 4-star plans, and you start to see a real, checkable gap between marketing and performance. Sitting in public federal data anyone can look up before open enrollment closes, insurers publishing denial rates near or below that 2% to 4% range now have to disclose that number publicly so you can actually ask for it before you sign anything, not after. A PPO structure gives you real flexibility if your health needs change or if you split time between states. And a free, unbiased second opinion exists specifically for this decision. Every state has a state health insurance assistance program, commonly called a SHIP counselor, who reviews your specific plan options at no cost and has no commission riding on which one you choose. That single conversation, before you sign anything, is the most effective protection against every trap in this video. Open enrollment gives you a real window to check all of this before committing for another year. And it works best as a short, specific checklist rather than a vague sense of caution. Pull your current plan's published denial rate directly from the insurer's website, since CMS now requires every Medicare Advantage organization to post it. Confirm every specialist you actually see today is listed in-network for the coming year, not just for this one, because provider lists are refiled annually and quietly change. Ask whether the plan is an HMO or a PPO, and specifically what happens if you need care while traveling out of state. And ask the person recommending your plan, directly and plainly, whether they earn more for enrolling you in this plan than in a different one. If they cannot answer that question clearly and immediately, treat that hesitation as an answer in itself. A SHIP counselor can walk through every one of those 4 questions with you at no cost, with no enrollment target to hit and no commission riding on your decision. That single free conversation, scheduled before your current plan auto-renews, is worth more than almost anything else in this video. The fine print in Medicare Advantage is not a secret because it is hidden. It is a secret because almost nobody reads 50 pages of an evidence of coverage document before signing. Now you know exactly which 3 pages to actually read.